It's an exciting day for all you guys. I hope that you guys find, what we talk about throughout the day helpful in your journey. Um, Let me introduce myself. I'm Rick Vitangcol. I'm a physician with the Permanente Medical Group in Sacramento. I'm a UC Davis Med School graduate back in almost 20 years ago now. So, and I've been involved in mentorship and student affairs for many years, along with medical student education, as well as residency education for a number of years as well. In my current role with the Permanente Medical Group, I actually am overseeing, partnering with UC Davis School of Medicine to put together a new combined medical school and residency track that will actually shorten the time of training for students interested in primary care. So again, today we're here to talk about family medicine. Is that what everybody's here for? Because I know there's been a lot of confusion about the rooms, and I greatly apologize for that. I'll take accountability and ownership for that, even though I don't necessarily make those make up the catalog. But again, I hope that you find that this time that we spend here in the next 40 minutes or so helpful for you in your own journey. I don't have slides, so nothing. There's nothing formal in our discussion today. I do want to have it interactive and have questions from you all, and I'll try to answer those as best as I can. So, don't be afraid to ask a silly question, because I'm sure the person next to you has the same question, and they're all good questions. So, and again, I also left a few of my business cards up front here. It has my direct contact information, email, cell number, whatever you need. Don't feel free to contact me if you just need some advice about your journey. Okay. So let's start off with who's here that's still in high school. Excellent. Welcome. Welcome. Great to think. I'm glad you guys thinking about this early. I was actually going to bring my senior daughter with me, but then she slept in. But anyway, but she's also somewhat interested in medical school, so we'll see. We'll see how that pans out. Who's here in college right now? Who's here locally from college? Okay. Who's here after college? Excellent. And anybody that's actually in grad school right now? Okay. All right. Okay. Okay. So, well, let's talk about family medicine. What is it about? A lot of people, they just wonder. It's like, well, I remember when I was in medical school, I used to think, well, what does a family practitioner do? And the reality is that you can do anything, which is nice about family medicine. It opens up so many different doors to you that, you have so many different opportunities. In training for family medicine, we take care of the whole family, from newborns all the way up to geriatrics. We deliver babies. We sometimes work in urgent cares or in ERs. We have a continuity practice, which is basically you take care of people over their lifetime. Again, ideally from the time that you deliver the baby all the way through, as long as you're in your own practice. And so, maybe 35, 40 years maybe. But the great thing also about family medicine is that you're able to take care of generations. And, meaning that you might take care of a parent, you might take care of their children, you might take care of the grandparent, and maybe even the great-grandparent, all in your own same practice. You might, again, deliver the babies of that family, and then take those young children into your own practice as well. So it's a very fulfilling type of practice that a lot of us really enjoy. And that's really why many of us went into family medicine. Many of us, because we couldn't figure out, we couldn't differentiate what we liked the most. Some people, they go into medical school or go through residency training, and they say, oh, I'm going to be a surgeon. Great. So they go down the surgeon track. Some people said, well, I'm going to take care of kids. I'm going to be a pediatrician. Great. So they'll go down the pediatric track. Some of us who go into family medicine are kind of like, well, I liked surgery. I like working in the hospital. I like working in the clinics. I like taking care of kids. Kind of liked it all. And so some of us come to that because of that breadth of what we see and what we take care of is just very interesting to us. It's very fulfilling. It's kind of taking ownership of the care that we provide for our patients. So, again, that's one aspect of family medicine. Some family medicine docs end up kind of specializing. Some people do, they just work in geriatrics and they take care of patients who are, over 65 or, very elderly that need a lot of special needs. And so, they might actually go through a geriatric, additional geriatric fellowship training, or that just happens to be their interest and that's how their practice, focuses. Some like orthopedics. They didn't necessarily want to be an orthopedic surgeon, but they wanted to do sports medicine. So then they do, they end up taking care of athletes. Many of them are, the physicians for, high school teams, college teams, and even professional teams. So, it's again a lot of different diversity in family medicine. But, again, aside from just the kind of the diverse group of things that you see, the other thing that's important about family medicine is the need that we have nationally for primary care physicians. As you may know, there is a large population in our country who, up until just very recently, didn't have medical coverage. They were uninsured, typically living in either inner city or rural parts of our country. But again, they didn't have coverage. And so now with the new healthcare reform, that's changing. But yet, even though people have insurance, do they have access to care? They might not necessarily have that. It's great to say I have insurance and you have the card that says, okay, if I get sick, I can go see somebody. But the reality is that with the number of people that we have in this country and the number of primary care doctors that we have in this country, it's not enough still. So the waits are still going to be long, potentially, if you live in an area that doesn't have very many primary care physicians. Granted, if you live in a big city, metropolitan area, probably not as big of an issue. Maybe even in California, at least in most of California. But there are pockets of our country, and also, again, in California, and also in big cities of California, where there aren't enough primary care physicians. So, one of the big things that we need to do is to really encourage you all, our next generation of physicians, to join me in our journey to take care of, our country. And that's really an important task because the goal of primary care is focused on prevention. It's not on taking care of a heart attack when it happens. It's not taking care of bringing someone to the operating room, or doing something in a procedure in a hospital per se. Granted, yes, those things sound glamorous and it's very rewarding, and they are. In training we all do those kinds of things, and I have colleagues who still continue to do those sorts of things. But in primary care, it's really about preventing things from happening. The thought of, why do we have to wait for someone to have a heart attack to take care of them? Why not just prevent it from happening in the first place? Making sure that they have, the appropriate counseling, the appropriate medications, the appropriate control of their diabetes, their high blood pressure, so they never get the heart attack. They never show up in the emergency room with chest pain, so they don't die from a heart attack, so that they're able to see their grandkids go through graduation. Those are powerful things. It's not glamorous. It's not I saved a life today. But the reality is, in primary care, you're saving lives every single day because you're preventing disease. And that's, again, a very important part of what we do. Certainly when someone has a medical condition and they, get sick, we're able to take care of them. We're able to, help control their diabetes better, help control their high blood pressure better, hopefully help prevent them from having other things. We're also there for them when they have a loss in their family. So many times many of my patients come in to see me because of what they're going through in their lives: stressors, grief, acute illness, chronic illness. So, what makes it, again, really interesting is all the different things that we see on a daily basis. I'll tell you that my schedule on a given day is never the same as the next day. So, I'll see, anywhere from like 18 to 20 patients in a day, do a number of phone calls, email my patients as well. And, they're all really different. They're all, it's not all just heart disease, chest pain, shortness of breath. I mean, it's everything, So again, it makes it very interesting in that way. But again, going back to kind of the needs of the country, we need to really focus on primary care, because in the long run, if you, again, prevent disease, then you won't need to take care of, it won't be as expensive, because that's the thing that we always hear about in the news. It's like, well, healthcare costs too much. We're spending 18% of our gross domestic product on healthcare. 18 cents out of every dollar that is spent in this country is on healthcare. That's crazy. We shouldn't be doing that. We have the most advanced healthcare or healthcare technology in the world, yet our country is not the healthiest in the world. We're actually more towards the bottom when you compare it to other other countries who have that that are advanced countries as well. So there's something wrong with that picture. We say that we're the best place to live. We have the most opportunity, but yet when it comes to our health, we're not. And so it is something that we all need to take ownership of. Everybody here in this room who wants to go into healthcare will need to take ownership of. And I think that's going to be an important thing that we move forward with. I want to open up to questions, and I thought that probably be I don't want to talk the whole time. I want to answer all of your questions, and see if we get some tangents off and some further discussion. So, does anybody have any questions today? Back in the corner.
Can you tell us like a typical day, like when you go to work?
Sure. Typical day. My practice is a little atypical, but because I do a fair amount of administrative work for my medical group. But I would say a typical day for most primary care physicians is that you have a clinical practice that has a group of patients who see you as their physician. When people ask, "Oh, who's your doctor?" They'll say, "It's Dr. Smith, it's Dr. Johnson, it's Dr. Alejandro," whatever the case is. And so again, my days typically I'll see anywhere from 14 to 20 patients in clinic in a given day. I'll get messages from patients by phone, but also electronically. And I'm fortunate in the medical group that I work with, we have what's called an electronic medical record, where patients have the ability to email me directly and with questions about their health or whatever else they have going on. And so I'll get those kinds of emails, anywhere from 10 to 20 in a given day. Some are simple, some are more complex. And again, there's some additional phone calls. Most of my days is pretty busy. I'm on the go, because you have a patient flow, you have your email flow, you have your telephone messages you need to get back to. But we have staff that helps us with that. I have medical assistants, some nurses that work in my clinic that help me with those things. There's a lot of charting, and that's one of the challenges of American medicine today, is that there's a lot of documentation that we need to put into our charts. But again, having an electronic medical record can help, especially if you're tech savvy. And I appreciate, this generation that you are all in are way more tech savvy than I was. Honestly, when I was in college, I didn't have a laptop, didn't even have a home computer. I had a little, the fanciest thing I had was this Casio typewriter that had one line at a time, and you made sure that whole line was right before you hit enter, because once it printed, you had no way to change that. But again, you guys are all tech savvy. I mean, by the time, if you guys go into medicine as well, into healthcare, your patients will be texting you back and forth. I mean, I never thought that I'd ever get emails from my patients before. But in the last 5-6 years, we've been doing, email exchanges. And so the new frontier will be FaceTiming, and that's certainly the thing that will probably be, Skyping and those sorts of things. And I appreciate there's a lot of newer technologies for that. But so I would say depending on the medical group that you work for, there might be call, which is kind of where you're covering for your partners after hours. I'm fortunate in my medical group that we have a system where we don't have as much call, but then our clinical days are very, they're very busy. But again, the great thing about it is that you have that continuity with patients. It's not, even though I might be seeing 20 patients today, which sounds like a lot of people, but I know them. I know them well. I've seen them over the last 15 years already. Certainly in the early part of practice, as you're developing your practice, it is hard because every patient that walks in that door, whether they're coming in for a sprained ankle, runny nose, or chest pain, they're all new to you. And it takes time to really establish that rapport with patients because that's really, honestly, extremely important. And I always tell my new docs who work for me that that golden visit is key because you want to have a great first impression with your patients. You want to really have that, that ability for them to trust you because, when they walk in that room, they potentially might be your patient for the next 30 years, or maybe for the remainder of their life. So that's really an important visit. Not to say that every other visit is not as important, but the reality is you really need to to really reach out to that patient and really build their trust. Kind of going back to that thought of trust. This is another thing that, because again, I teach a lot of medical students in my own clinic. And the one thing I always remind them is the great gift that your patients are going to give you. And that's the gift of their trust. It's amazing. And honestly, over time, I have to keep reminding myself of that. And that's why I love having medical students working with me because, it really grounds me. And, because you hear about, doctors in training that they kind of, they start becoming impersonal because of, all the work hours that they do. All the, the late nights and overnights that you're up taking care of patients and you start to become kind of negative at times. But again, the thing that's really important to remember is that as you walk, it's amazing. As you walk into that room as a person's doctor, maybe even for the very first time in that golden visit, that person typically they have an implicit amount of trust already for you just because they're seeing you as their doctor, and they open up to you in ways that they might not open up to anybody else in their whole world. They might not even have talked to their spouse or their family member, their kids, their clergy, whoever. They might not have told anybody else, but they're going to tell you after you've met them for 2 minutes. That's pretty amazing. And it's not that I'm a special person or any doctor's special person, but it's that, it's that implicit trust that they develop in us. And that's, again, something very powerful that we as healthcare providers should never forget. That's something that we need to make sure that we remind each other and remind ourselves all the time because, if we start to think that we're better than anybody else, then that's a problem because we're not. I'm just Rick. When I'm out of the office, I don't typically have a suit on. I don't have a white coat on. I don't have a stethoscope hanging around my neck. Nobody knows that anything else outside of that. So I don't even have a problem with my patients calling me by first name. I don't care. That's cool. That's fine with me. Because we both must have mutual respect for one another. Patient for me, and myself for my patient. And so that's, again, a really important thing to remember. So thanks for that question. Yes?
Well, I'm a high school student. I was wondering, in going to college, what would be a preferred undergraduate major?
Sure. So the question was, as you're preparing for college, or even if you're in college, what should be your major? In the past, everybody used to say, oh, well, you got to be a science major. You got to be biochem, biology, physio, something in the sciences. I'll tell you that that's probably not true anymore. Or maybe it never was, never should have been. The reality is that, because I also sit on medical school admission boards as well, and the reality is that you need to have passion for what you do, whether that be, English, Spanish, humanities. Yes, you do have to take certain science core classes as undergrad to apply for medical school, but it doesn't have to be your main focus. Granted, when you get into medical school and you start doing the basic science classes, it may be a little bit more challenging if you never had the exposure to it, but it's not insurmountable. The thing that I look for in a student is really about their ability to work as in a team. It's not all about me. Yes, you got to be smart. Yeah, you got to do well. You got to do well academically. You have to do well, unfortunately, on various tests. But I'll tell you that the trend in medical school admissions is not towards the just about your MCAT score. Yeah, I mean, you got to do well on the MCAT, which is the pre-entrance exam. But many medical schools, including UC Davis now, use what's called a it's a kind of a mini interaction interview process where instead of having classically 2 interviews, one with a faculty member, one with a medical student, that you spend an hour just kind of talking about things. What a lot of medical schools are doing is there's short 8 to 10 minute interactions with multiple people through that day, and they ask you to actually kind of go through scenarios, maybe sometimes even with an actor student or with a person who's acting like a patient, and just to see how you interact, how you deal with, when someone is maybe challenging you, in a way, to see how you would interact with them. How can you diffuse, a difficult situation? You don't necessarily have to have medical knowledge to do that. It's really all about you innately as a person. Are you a person who, goes on the attack and yells back? Or are you a person who tries to help that person realize, have some empathy, have some understanding of where that other person's coming from, and how do you deal with that situation? And so again, it's not all about what major you have. So for those of you who are still applying or are going to start college, I would say do what you're interested in, do well in that. But again, it doesn't have to be a science-based major. Even back in, again, I started UC Davis Med School in 1992, so 21 years ago. My class back then, I would say only half of us were science majors. The rest were of all different sorts, and they all did well. So, and many of them did way better than I did. So, anyway, yes.
In terms of your hospital rotations in residency or medical school or whatever, what made you decide exactly to go into clinical practice rather than working in a hospital?
Okay. So the question was, during medical school training, especially in the last, 40, 50 years, it's been heavily hospital-based training. So a lot of time that you spend in the ER, taking care of patients in the hospital, in the operating room, those sorts of things. And so her question was, what made me decide, or what makes people decide to do a more of an ambulatory, or let's say a clinic-based type of practice? I think everybody has a little bit different reason why they do it. I think one of the reasons why I chose it is because of the continuity. I really love having the continuity with my patients and really getting to know them extremely well. Not just the times when they're super sick, because I will still see them when they're super sick, but at the same time, it's nice to see them just for, a well visit, kind of quote an annual physical, or just to kind of check in on things. Because I'll say that even a good portion of my day is just social visits. Just say, hey, it's great. Last time I saw you, your son was going off to the Air Force. How's he doing? Or I hear that you guys have a new grandchild. That in your family. Have you had any great trips lately? I mean, granted, it's not medical in any way, at least in the true sense of medical, but it allows us to, feel like I'm part of their family. And I think that's one of the draws of family medicine. It's because you really truly feel like you are part of their family. You're not just a doctor that they're seeing once every year, once every 3 years, or whatever the case is. It's like you really do feel like, I have, a number of patients where, I get invited to holiday parties, I also get invited to funerals too. I mean, and so, it's it's a very powerful feeling, and very, very, it really does fulfill you quite a bit. Again, a lot of my colleagues who do more hospital-based medicine, one of the advantages of that is that, there's not as much, not having the continuity, you get to hand off things to your colleague. So when you're off, which is a nice thing. So kind of finding that right personal and professional balance, because that's going to be important to do over the course of your lifetime, because you have some decisions to make as far as how much your professional life is going to impact your personal life. Unfortunately, there's only 24 hours in a day. I wish we can add more sometimes, but the reality is you have to find that balance. I mean, you have to find that balance now. How much homework you're going to be, how late you're going to stay up to do your paper. Am I going to do one more revision of this paper before I turn it in? Or am I going to just say, it's good enough, And so, some of the advantages, like some of my colleagues who work in the emergency room, they work their shift, whether that be an 8-hour, 12-hour, whatever number of hours a shift. But when they're done, at the end of their shift, they hand it off to the next person, and then they take over the care of that patient. So when that person's off their shift, they're done. They go home, they can go to sleep. They don't have to worry about, did the lab come back abnormal? No, their colleagues taking over, which is nice. I mean, it gives you that ability to kind of separate work from home, which is nice. In a continuity practice, there's more of a blur. I'll tell you that this morning that I logged into the computer and I checked my patient's labs before I came out here. I'll probably check it again later on tonight. But that's just, something that we're responsible, it's that sense of responsibility that these are my patients. They belong to me. They rely on me to get back to them. But, the flip side of that, at least in my own practice, I'm not on call every fourth night, so I can sleep in my own bed at night, as opposed to sleeping in a hospital call room. So there's some advantages there too. Other questions? Yes, in the back.
What are like your typical work hours?
Work hours. So the question is, what's the typical work hours? I mean, you probably hear huge extremes or scary thoughts, and I'll tell you that, yeah, some of those things that you hear are true to some extent. Especially, I remember back when I was in training back in the 90s, even beforehand, there were times where we were on some clinical rotations where you would work a 36-hour shift straight, and then you'd be home for 12 hours and come back and do it all over again. And it was crazy. I mean, I'll tell you that there's times when we thought we were unsafe. And we always thought back then, there should be a law that should be passed to say there should be a limit on how many hours that you can work in a given day, given week. And now there are. So there are certain rules that, residents and medical students can't work. I don't know the exact details of what those rules are, but it's certainly it's much less than they used to be as far as, those limitations. And so, I think in general, most of us, we do, if you're a, quote, full-time person, you work full-time, most of us are still working more than full-time to be able to get all our work done. I would say probably in the order of about another 20% more. So, if you're a, let's say a 40-hour person, then you probably work 40 to, probably like 50 hours or so, depending on how efficient you are. So it really kind of depends. But it's not, it's not undoable. There's a lot of people in a lot of other types of careers who probably work way more than I do. I have friends who are, stockbrokers who they're watching this, they're watching the ticker across the TV starting at 4 a.m. because that's when New York opens up, or already London has opened up, and then and so their days are different, can be very hectic as well. But again, everybody's practice is a little bit different. But I would say that you certainly I would say we don't punch a clock. So if our patients need us for certain things, as a professional, we have to put our patients first. But certainly we try to work in teams to hopefully to minimize that that challenge of having to always be in the office or in the hospital all the time. And so that's the beauty of being in a group practice. You have that flexibility. Yes.
Can you talk a little bit about your journey getting through undergraduate school and graduate school?
Sure. So I grew up in the Bay Area, and I came to the United States as a young child, and lived in San Francisco in the Mission for a period of time, Daly City, and then moved up to Benicia, which is a right outside of Vallejo in the Bay Area. Small high school. I probably had 180 in my class, graduating class, and not very many of us went to college. I mean, I would say maybe less than 10% went to a four-year university straight out of college. I went to Cal for undergrad. I was a physics major. So your question about what major were you at back then? And honestly, I didn't think I was going to go into medicine back then. I thought that I grew up in a family where nobody was a physician in my family, but my parents wanted me to be a physician ever since I was a little kid. And how aunts and uncles, they say, "Oh yeah, Rick, you should be a doctor," that sort of thing. So I was kind of pushed back on it. And I was like, well, no, that's not what I want to do. And so, I thought I was going to be a physicist working at Lawrence Berkeley Lab or something like that, working with lasers or something really unusual. And I got into college, and honestly, I struggled. I struggled a lot. I remember being in classes where I just felt I don't belong here, and I don't know, I don't know exactly I wasn't prepared for it, or it just wasn't the right fit for me, or whatever the case was. And I even got into this upper division physics class, and honestly, the first day of class, I just totally, I told myself, I really need to change which direction I go. And so, and I started thinking again about medicine. Is that something that I would like to go into, as opposed to this basic science type of pathway? I really enjoyed working with people. I really enjoyed taking, back then I was even volunteering at some local clinics, and it was a lot of fun. And so it kind of turned me towards that. But I wasn't prepared to apply for medical school. I was already a junior, almost a senior, and I was like, well, I need to just kind of sit back and kind of graduate, finish up, and kind of go from there. So I ended up switching over to biophysics because I didn't want to extend my college career too much longer, and so it kind of led me down towards more of a towards medical school type of pathway. But again, I still needed to take the MCAT. I still needed to study for that, and so I took the next 2 years off, and I worked for a biotech company in the Bay Area. You guys might have heard of Genentech, and I worked for Genentech for a couple of years. Worked in a lab, and I thought, well, okay, while I'm there, maybe it'll help me decide, do I truly want to go into biotech or some kind of grad school or into medical school. I loved what I did over there. I had great friends who I worked with and did some really cool stuff. Was able to get published with some of the scientists there, with collaboration with some folks for UC San Francisco. And so that was really cool. It was a lot of fun. But I didn't see myself working, in a lab all day long. I mean, kind of for my career. I missed the change in interaction with different people. Even though I really enjoyed my lab partners and all, but it was just nice to have that ability to have more flexibility. And so I did apply for for medical school, studied during that whole time. You know, Kaplan's was not really available to me at that time. It was just too expensive for me to attend. But you know, again, it's a wonderful it's a wonderful opportunity if you have that option to do. And then applied to medical school. I was fortunate to get a few different interviews around the country, Indiana, Penn State, and then UC Irvine and Davis, and then I forgot one other school in Philadelphia. And I was always told if you get 5 interviews, the likelihood is you'll get at least one of those acceptance. And so I was fortunate to get accepted here at UCD, and it was definitely my first choice of the ones that accepted me. What I loved about UC Davis was, one, back in California, so I didn't have to move anywhere. But 2, the focus on primary care was huge. The focus on student-run clinics was huge. And so for those of you who are here at UCD, probably work in some of the student-run clinics, which is a great opportunity, and I really encourage you to continue to do so, even when you go into residency and medical school. And then also during that time, my wife and I got married before medical school, and so because we had been together since high school, and so and then we started our family during at the very beginning of residency, and now I have 4 daughters. Again, the oldest one now is graduating high school this year. Gosh, that's amazing. That's happening so fast. And I also have 3 in high school now, and 1 that's still in 6th grade. And so, trying to balance everything is very challenging, because you want to still be there for your family, because that's an important part of who I am. I'm very involved in my kids. 3 of my daughters are cheerleaders, and so I'm actually one of the cheer parents, and so I actually do all the pictures, do the websites. That's another thing I was doing last night, loading up pictures from homecoming last night and doing that. So, my Instagram tagline is DHS Cheer Paparazzi. So, I mean, it really is, I'm not a doctor outside of work, honestly. But, we all have different pathways to get there. I have a friend of mine who, he was, he came from a very challenging background. I mean, he was told by many counselors along the way, you shouldn't be a doctor, don't even try, and he just, he said, no, I mean, this is my passion, this is what I want to do. And he honestly was one of the smartest kids in our class. And so, don't ever let anybody tell you that you're not smart enough to do something. And the other thing to say, just as a sidelight to that too, in family medicine, I would say it's better now than it used to be, but the respect from some of our colleagues in subspecialties isn't quite as strong as I would like it to be. A lot of people kind of look down at family medicine, or what some people term GPs or general practitioners, which I don't like that term because that's not what we are. But because we didn't specialize, we didn't do a fellowship after residency training. So, so the thought is, oh, we're not as smart as they are. The reality is that we take care of a wider breadth of types of things. So I have to be able to know everything that kind of shows up in my doorstep, not just the cardiac stuff, not just the pulmonary stuff, not just the orthopedic stuff. I have to know enough to take care of all of these different things. I might not be the definitive person to take care of it all the way through, but I need to be able to identify it and be able to take, and make sure that my patients are safe. So, again, one of the things that sometimes can happen is that people might come to you and say, you're too smart to go into primary care. You're too smart to go into family medicine. And I'll tell you, don't let them do that. That was, many times I was told that through my training. And if you're a non-traditional student, don't let them pull you down either. Because I'll tell you, I was not a traditional student. I've had these earrings on ever since I was in high school. So I'll tell you, people kind of look at you kind of a little funny at first, or they might say, but the reality is you're going to prove to them what you got. And, so stay true to yourself. So any last questions? I know you guys might need to get to another session, so. Yes.
Has there any been, like, crazy question, at any point in time in your life have you became burnt out?
Great question. So the question is burnout. So the whole issue of wellness, you know, we promote it so much in medicine for our patients. At the same time, we as physicians as a whole are probably at a higher rate of burnout than the most, just because of the volume of work that we do. You know, and so we have to really help support one another. You know, I'm fortunate. I belong to a medical group where we really focus in Kaiser Permanente. We really focus on wellness for ourselves as well. So, you know, but not to say that that people don't burn out. People get, you know, get stressed. Yeah, many of my colleagues do get stressed, and I would say, you know, you know, the reality is that we're humans too. We're not any super person than anybody else, and so we need to identify when we're starting to get burned out, because when we're burned out, then we're not going to provide good care. And so it's important for us, especially in a group setting, to be able to help support each other and identify when that's happening. And so I'll actually go to one of my colleagues and say, you know, I'll take this next patient, go in your office and just, you know, chill out for a little bit, and we'll, you know, we'll get you the support that you need, whatever the case might be. Take them to lunch, you know, give them a day off, whatever it might need. And so we really need to help support each other. But yes, the burnout rate is still high, but again, we're trying to fix that. All right. Well, again, I thank you guys for coming today, and certainly if you have any additional questions, again, you're welcome to take one of my cards. Feel free to email me, text me, call me in cell, whatever you need. Okay? Good luck with you guys. All right, you're welcome.